clinical space. Today, the Division of Interdisciplinary Palliative Care and Medicine is leading this talk, and we are very fortunate to have Dr. Craig Geoff Howes, who is going to do our lecture today, and he's going to talk to us about tech-integrated palliative care. I think it's very important to realize that AI is here with us, and we need to start using it with safety, and we see our students using it, but there's also great advantages of using it in the clinical space. And how can we then use it in the clinical space? Dr. Howes has got, he's a UCT graduate. He's got a PG DIP in palliative care. He's got a master's in palliative medicine from the University of Glasgow. And he also has a PG DIP in emergency care. So he's a real proper face employee. And he also, I was told very clearly, he is a bagpipe. He's part of a bagpipe band. And you can hire him. He's especially good at funerals. So if you need any bagpipe playing, he is your guy to go to. So thank you, Dr. Howes. All over to you. Before we go on, if you want CPD points, please add it into the chat, your name and your MP number. Thank you.
Thank you so much, Renee. I see Renee very cautiously skated over my first names. I go by Geoff or Craig Geoff, yeah, so I'm so happy to be here and talk about this topic that I'm really passionate about. It is slowly working its way into the foreground of my life, and I'm starting to focus my research in this direction. But yeah, I hope that I can give you some practical tools and something to think about when considering tech integration, and particularly where tech integration meets AI. So what I'd like to just talk through is, just by way of housekeeping, if you've got a mic on, please just mute it. I can't see anything that's happening except my slides right now. So if there is a question, pop up your hand, and Renee can direct me to the fact that there is somebody talking. All right. So the outline of this presentation, it's not a very technical presentation, and I really hope that it is really accessible. I'm going to go through these 4 things. I'm going to initially talk about a tech integrated workflow. This is going to be based on my experience, and it is framed around my experience with healthcare at the moment, and that is from a virtual health point of view. Yeah, my primary role at the moment is as a palliative care provider in the virtual space. It is actually quite uncommon now that I see a person in person. It is quite a specific type of space, and so if it looks like it is different to yours, it is because it is true. And what I'd like you to kind of reflect on what my lessons can teach your own experience. So I'm going to go from that workflow, and then I'm going to talk about my tech integrated toolbox, which will then allow you to think about your own. And how you can introduce tech into your life for efficiencies, for the things that tech is very good at. I'm then going to just briefly outline what is actually available from a guidance point of view. I'm going to be using one very important document from the HPCSA, which guides the use of safe AI. We've been quite late adopters and late regulators in the use of safe AI. So I'm going to direct you to that document and talk you through some of the basics there. And then I'm going to finally just talk about 5 lessons that we can learn from some of my experiences. So without further ado, let's talk about tech integrated workflow. So this section, I'd like you to sit for a moment and just consider for yourself how integrated is your practice already. So as I'm going through this content, have a think about where your practice has already taken on some of these things. What tools are you already using? So the workflow that I conceived was from a patient point of view, and we're working around a single patient as opposed to coming from a practice point of view, managing many patients. There's clearly many ways that we can approach this. But I think what is really important is that the way that our practices are built are really around person-centered, family-centered needs. As these people face their serious illnesses, it is about their experiences, their beliefs, their health literacy, how they access healthcare. And really at the root of this whole workflow is this complicated experience. From there, in my virtual healthcare space, I primarily am dealing with a single stream of patients, which is from the aligned universe. Yeah. That recognizes the importance of virtual healthcare in order to scale access to palliative care. So that's where I'm going to talk from. So I'm going to speak about screening. So screening in that space is done by funders. So funders are trawling their own claims data to try and understand where patients might benefit from specific palliative care intervention. It then goes on from there to assess those patients that come from that large pool of data, and to the surface rise potential candidates for palliative care. And then the team that I work with, Aligned, assesses those patients using specific tools to assess for palliative eligibility, so referral to specialist palliative care. They then go about a process of identifying a palliative provider from their registered service provider lists. They then refer to me, and then suddenly I start having control. I onboard the patient, arrange an initial assessment, and then actually carry out that initial assessment and create a workable plan for that patient. From there, on the back of that assessment and plan, I create feedback. So all my patients get a detailed letter that goes back to usually the current managing team. So that's usually an oncology team. So the Aligned Universe doesn't have a lot of space for non-oncology work. It does crop up, but there's no specific funding structure for that. So I integrate with that team. I do not do that extremely deliberately, and I'll explain that in a little bit later. And then building a team around those people. So usually that means accessing resources that are already in that area. Then on the back of that assessment plan, I have to pay my bills somehow. I think all palliative care providers in the room will appreciate that sometimes that's a hard thing to do. And so billing is a critical part of this workflow. And then what's more is making sure that that money comes in is also a very critical step. Thereafter, this patient is onboarded into the practice. There is a follow-up process that goes on in my practice. I'm going to be quite deliberate and tell you about my follow-up as a consulting provider, as opposed to a person that's there on a day-to-day basis. And then disposition of that patient. So clearly in palliative medicine, we are quite used to patients exiting our service when they die. But they also may be eligible for palliative services to assist with sort of difficult to control symptoms in the context of serious illness, and then do extremely well and then get discharged. In this space, I recognize there is a space for interdisciplinary collaboration and supporting that IDT. This is not something that is very built into my workflow, but as a consulting provider, but yeah, this does come up. So what I want to put to all of you in the room is, bearing in mind that workflow, I want to ask you, consider your own workflow, however you wish to view it, from a patient lens, from a provider lens. Have a think about that workflow and ask the question, where do you actually have influence? This is going to look very different for different people in this room. And clearly, me as a sort of clinician, academic person, where I have influence is different to somebody who's spending a lot of time in a clinical role, or or an academic, or a social media type of a clinician that's giving advice. So where you have influence is going to look different. And I went back to my workflow and just kind of highlighted in green where I think I have quite a lot of influence. Clearly, this is not perfect. And my initial slide here actually had a lot of different colors, and it became quite confusing. So for me, in these elements in green, I recognize that I have influence in the onboarding and arranging of assessments, in the initial assessments and plan, in the feedback, in the billing. You'll see that I've deliberately left out collecting. There's not a lot of control once that enters into the funder space, apart from just following up. And before I put that in yellow. But oftentimes you'll find that collecting disconnects from your sort of locus of control, and patience is really what's there. And then follow-up and disposition, yes, certainly IDT collaboration and support is something that you have a lot of control over, and depending on how you structure your practice, this might be very much integrated into your workflow. However, as soon as you're starting to introduce other people, other people's needs, and other practices' needs, and particularly in my space where I'm collaborating with many different practices, clearly I don't have a lot of control, and particularly where they are already running an IDT in their practice. My role is as a consultant. I'm here to offer perspective and then return your patient to you. What was interesting for me as I was putting through the slide was I was surprised to see how little of this entire workflow was clinical work. And this is taking a step back from the workflow. It's interesting that we are trained as clinicians and we spend so much time on these two elements that actually are a very small part of the work that we do or the work that we are involved in. And so what I want to point out here is that as part of a larger system, when you are considering how to integrate tech into your workflow, you cannot only look to your clinical facing time. And that's the lesson I want to put there. The clinical interaction here is almost like a very important, but a small blip on this large system. It's very quiet, Renee. I just want to make sure that everyone's still there.
Everybody's still here.
Fabulous. Cool. So from here, I want you to ask yourself, where do I need support as part of this very, very large system? Where do I need support? Because if you don't need support, do not upset a system and start engaging with things that you don't understand or need. So this question, I think, frames exactly how we're going to start approaching integrating tools here. If you don't need them, don't use them. So the next thing I want to talk about is a toolbox. So like what tools you actually can use. And here I want to ask you, how integrated is your practice? What tools do you already use? And I think before you entered in this room, you might think that your practice is not that tech integrated, and maybe it's not. But I challenge you to not be using a lot of these tools. So I'm going to go ahead and just outline some tools. These are just some that I use and some that I'm aware of. There are clearly many. So on the left-hand side, I mentioned that general tech. General tech is sort of that tech that is already integrated into your life. These include things like email and WhatsApp and other messaging platforms, You might have a messaging platform within your practice or IDT. And a lot of these general tech tools actually have AI tools integrated into them, and you can find those tools. For instance, your Gmail has, if you use Gmail, you would have access to Gemini that assists you with inbox management. WhatsApp has Meta AI. And yeah, so WhatsApp already has got Llama built into it. So there are already general text that is part of your life that's actually already making use of AI. So and so possibly when you are thinking about how to change your toolbox, you might consider just using the tools that you already use and learning how to make use of the efficiency AI tools that are built in. Then clinical tools and narrow algorithms. I think this is one thing that strikes me when I look at AI and Gen AI is a lot of the way that these tools function is using a very complicated, but this is an algorithmic approach to do a bunch of things. And really, what I want to point out is that before the advent of accessible AI, we were all using clinical tools and narrow algorithms already. I think in the palliative care space, we've got a very clear, accessible tool around palliative eligibility, which is the SPICT tool. This is kind of an algorithmic tool that allows us to identify palliative intent. Think of the ER. The ER is filled with algorithms that assist doctors at the moment, recognizing dangerous chest pain, managing MIs, managing CVAs. These are all algorithms that are already there. They're already there, and they are based in evidence. And AI can automate a lot of these things, which otherwise can be quite pesky. So in this way, you may be able to optimize tools and algorithms that you already use and build an assistant to assist you with managing those, instead of having this sort of fractured approach. Then there are a couple of day-to-day management tools that I think almost everyone is experimenting with. A lot of Gen AI tools. I am a ChatGPT fan. ChatGPT 5 has just been launched in this last week, and it's a much faster, a very accessible, user-friendly tool to use. A lot of people make use of Gemini. It's built into Google, but also there's a lot of capacity there for growth. So AI assistance and creating specific tools from these tools, AI agents to assist you with some specific process. Those are things that you can investigate. And then there are a lot of organization tools like Miro, and Notion that are just sort of day-to-day like creativity facilitation tools, or managing complicated schedules and things that go beyond just a simple calendar. So that on the one side is just like, this has nothing to do with medicine, but might, or I mean, the narrow algorithms clearly do have a lot to do with medicine. I think I put that on the wrong side. But clearly there's a lot of stuff that already exists, already there, you can use. Now to the right-hand side, so the clinical facing stuff. There's a lot that we can build in, and this is where a lot of you would not have experimented or may not have experimented. I think there's a big shift in the community to electronic medical records, and so your electronic medical record may have certain built-in functions. I make use of Healthware because of my association with Chariot Health. This is their electronic medical record, and then I also make use of Huku, which is a platform that allows you to share information amongst the team. Gen AI helps me a lot, and I'll cover that in a little bit. Clinical support is something that I have not experimented a great deal with, but I think those, there are a couple of fields that are making a great deal of use of this function. Radiology is one of those. I see at Vincent Pallotti, they've got AI-assisted planning for radiation. So there's this sort of diagnostic and treatment-assisted, AI-assisted support, and clearly that's under the supervision of doctors. But important there is electronic scripting. Electronic scripting is something that has sort of like just boomed since COVID, which really made visible this problem that scripts were like physical scripts were kind of old world, and we can actually get beyond that. EM Guidance has a scripting platform, which is very useful. And then collaboratives tools. I make use a lot of these. I've listed them there. I don't want to get too in depth, but I'm going to go through my toolkit in a moment. So there we go. One person can use many of these tools, and you need to figure out how they're all going to fit together in your life. I really appreciate this llama that kind of puts its head out in the middle of nowhere. So what does my day look like? So my day, a day in the life of me, when I wake up on a clinical day, this is essentially my my view, the panel that I see. I wake up to a day of scheduled patients. I open usually 6 or 7 tabs, depending on what the day holds. I'm going to speak you from left to right. On the top left, you'll see that HIPAA compliant app, and that is Huku. So HIPAA is just essentially privacy legislation, international privacy legislation, a lot like our POPI Act here. And this tool is POPI compliant or POPI equivalent compliant. And that is the tool that I use to share my notes with a wider community. The next tab there is Healthware. That is my electronic medical record that allows me to store consults, scripts, letters, everything that I require. And then we go to Heidi. Heidi is probably the one tool that changed my life in an extraordinary way. Heidi is a note-keeping, a clinical note-keeping assistant. It is a very simple tool that is AI enabled. Essentially, it takes a transcript without very much in the way of it's not very specific. It doesn't know who says what. It takes a blank transcript that then it analyzes using their algorithm to put out a very specific to put out an organized note. And using this tool, this has saved me a great deal of time. It allows me to it allows me to really focus on the patient, on the families, without being distracted by my notes. My brain works very well when it is not stressing about keeping detailed notes, and I know that it's keeping a good note. And when I'm finished with that and it generates the note, I can alter that at my leisure to make sure that it reflects the consult. The next tab is ChatGPT. I subscribe to ChatGPT. It is one of the most wonderful subscriptions of my life, for my personal life, for my professional life as well. And ChatGPT, being a subscribed member, allows me to do a whole bunch of additional things that makes my life a lot easier. And one of the things that this enables in my day-to-day existence is to convert a clear assessment from the Heidi platform to notes that are in my voice that I can then create a letter, for instance, to an oncologist, or an update to a funder, or an interdisciplinary note for the meeting. Heidi can do this too, by the way, and for me, this is a function of me needing ChatGPT for a whole bunch of other things. And so I already pay for a subscription with ChatGPT. I don't need duplication. Then I've got my email boxes, I've got WhatsApp, and then often another source of information. So being associated with UCT, I'm often making use of the Health Sciences Library, and that's the last tab there. I'm going to come back to this in a moment, but I just want to go, I'm just going to check in again, make sure everyone's here. Renee, all fine?
Yes,
All
we are
fine.
here.
All fine.
Okay, cool. Great. So, what is out there already? How do we know how to use these tools? How do I know how to use these tools? The truth is that we were left in the dark for a good amount of time. While sort of legislation and guidelines were catching up with the technology. And in many ways, this is very helpful because it allows us to get a good indication of what is safe before it's legislated, and then we go from there. But I want to share with you a document from the HPCSA. It was written in 2024, late 2024, I think about September it was released, which details the appropriate use of AI use in healthcare. So I'm not going to go through the whole document, but I do want to point to, towards the end of the document, this document outlines these pillars of AI implementation. And for me, these are probably the most helpful things. I feel like I'm speaking to the converted here about ethics. I feel like everyone can intuitively understand that if you are using a tool in the healthcare space, it must be compliant with standard ethical principles that are widely accepted already. And I think this is practically very helpful. But there's one thing that I must point out from here is ethics. I mean, we're all quite comfortable with the application of Beecham and Childress principles, and a lot of us, particularly in the palliative community, I mean, we spend a lot of time thinking about ethics. We might have our own sort of ethical frame to unpack and understand the work that we do. I'm going to stick with Beecham and Childress just because it is a model that everyone is familiar with which everyone is familiar. And yes, AI is very good at honoring autonomy, non-beneficence and maleficence. Extremely good. Autonomy is obviously only as good as the information we give it, but beneficence and maleficence are things that AI can hold very easily. And there's quite a lot of safety mechanisms built in there. But justice is not well served. We have to consider, when we consider rights-based justice, it is clear that AI can use data from rights-based documents that are in existence. But we know that our world is untransformed. We know that the world is formed by power dynamics, by wealth, and as a result, the values that are embodied by AI very much represent a westernized, educated, industrialized, rich, democratic, white, Anglo-centric world. And justice, when we consider justice in this way, and I'm going to unpack this a little bit later, if we don't consider those elements, we can be caught out. So ethical compliance, yes, but we must be cautious about the outputs of AI because it is bound in a value system that does not necessarily belong to the context in which we are using it. Legal applications, I think I'm also speaking to the converted here, is that clearly if we are going to use AI and we are going to use this tool in healthcare, it must be legal. I think an important consideration there is that clearly AI can only apply what is out there, the data that is available to it. And bearing in mind that AI is using vast quantities of data, a single precedent that is set in a single court somewhere, you know, this one massive milestone in a change of, I don't know. I mean, we're seeing a lot of sort of assisted death legislation coming out, for instance, at the moment. The shift in AI values is going to take time. And what's more, it's not going to necessarily be contextually relevant. So legal applications will be delayed, and they are going to reflect the values of the global majority, or certainly the world. I think the term global majority is often being used to describe what we would have previously said low and middle income countries. But actually what I'm talking about now is not that specific application of the work. I'm talking about globally produced data. So what data is actually available, that is what AI is going to base its opinions on. And clearly it is going to take time for it to shift. So legal application, yes, it's probably okay, but it's going to be a delay and it's probably not going to reflect your context. And then the last thing here is technical competency. When applying AI, I think, again, this is intuitively true, but I think a lot of us are experimenting with AI outside of the professional space, and it might be difficult for, it's difficult to know your sort of AI literacy yourself, because you're only engaging with the tasks that you're doing. So it is difficult to know how competent you actually are with these tools when you are using them. So you have to be reflective. You have to make sure that as you are learning about it, you reflect yourself. Like, am I feeling competent in using this tool? So these are very useful pillars as we implement AI. The HPCSA also produced this was actually a media release about the use of AI tools to generate social media content. And that was this year. But I found this phrase that or at least this extract, very helpful. Regardless of how content is generated, health professionals remain accountable for any material published under their name or associated with their practice. I think that is a reasonable conclusion. Using AI does not absolve practitioners from adhering to HPCSA ethical guidelines and rules. And specifically, the practitioner will be held responsible. So that is a very useful thing to, as you are introducing these things, remember that responsibility lies with you, and probably always will. So the question I want you to ask yourself is, should I change the way that I practice? And if you answer that with yes, I want you to answer why. Why do I want to change it? So for the last little bit of this presentation, I'm just going to speak very briefly about my personal journey and then speak about some lessons that I hope to share with you, and I hope that you'll be able to hear. So my personal journey with AI has been extremely positive. So I think that is the place that I want to start. Is AI has allowed me to improve on many elements of my day-to-day life, and this is with a fairly rudimentary understanding. I'm using it as kind of a lay user with a skill set that is rooted in healthcare, but yeah, it has really improved my day-to-day life. And what is really fabulous is that this tool has allowed me to optimize on things that I'm really, really bad at. And in many ways, it has allowed me to kind of define my role much more clearly for myself. So I'll give an example. It's allowed me to complete sort of admin elements that I'm so bad at completing. It's allowed me to engage in this virtual practice where funders or a value-based organization like Aligned has specific requirements. And without AI, I don't believe that I would have been able to keep up with those requirements. So it allows me to generate a good note rapidly. It allows me to put it on the shared platforms easily. From there, it actually enables me to create feedback letters easily. And so, yeah, from a professional point of view, it's really helped. And it has, in many ways, as I've learned this, it's allowed me to reflect myself that I am not a great clinician without a great deal of help. There's a lot of stuff that I'm extremely good at, but there's a lot of stuff because of my own mental health stuff or the way that I work, that really get in the way of me being a good clinician. And so this has allowed me a space to have significant help without the huge expense of people. So so that's been really, really helpful. It's allowed me to grow as a clinician and a researcher. So it's really created this very efficient life that allows me a lot of space to downregulate. So I have clinical days, I have writing days, I have a life that is balanced, and largely I could do a lot better in making this a productive, a lucrative life. It's not something that is very high on my values list, and I think if I were to stay in this life over the long term, it would require a lot of optimization. But it has allowed me a certain comfort in the things that I do, and it's made me better at that. And they all kind of fit together. So without so yeah, I mean I like this idea of a comb, that everything is kind of interdependent, and really, like all of these parts, the fund identified potential palliative patients, which are, this is a very complicated algorithm, and it is AI assisted, and tech assisted anyway. It all feeds into my clinical assessment, how I feed back to the medical aid, notes and feedback sharing amongst an IDT, simple tools, email tools that keep me on top, simple standardized templates that I use in an intelligent professional mailbox. WhatsApp, Lordy, where would we be without WhatsApp? And particularly WhatsApp Business, that has these intelligent elements that allow me to create boundaries and create navigation and navigational aids for patients. So when patients contact me outside of my clinical hours, they get an automatic response that says, sorry, like I'm outside of my clinical hours and you're not going to get a response, but this is what you can do. And these are simple tools that have made my life so great. So really, I'm so grateful for the addition of AI in my life, but it is not without a great deal of teething. I want to share with you 5 lessons that I think we all need to understand. And these 5 lessons I'm going to share are really, I would like to demonstrate to you that the values landscape that you occupy in your life may not be that of AI. And it might be that there are some shared mountains, some shared hills, but we lead our own individual, our context is really important to us. So I want these lessons to kind of teach that that these landscapes might be quite different. And I'm going to give you 5 lessons. The first lesson I'm going to frame around this fundamental start to the workflow that I mentioned earlier. This person, the experience of the person who's going through serious health. And we have to understand that, I mean, clearly we've got our own values, we exist in our own space, so does that person, so do their families. They are experiencing the serious healthcare concern. And as a patient who is being faced for the first time with a serious healthcare concern, I'm going to frame this around a patient who's just been diagnosed with pancreatic cancer. We all understand that work in the space that pancreatic cancer is a serious and a bad diagnosis to get. Prognosis is poor. It's often diagnosed late. There's a lot of reasons for that. Treatment options are not great. We know that they do something, but like you have to have very good goals of care to understand what we're going to do. So I want to just make you think about what might happen to a patient when something like this happens. I'm going to say to you that this patient goes to ChatGPT. It's a very accessible tool. There's a free version that people are often using to assist them. I'm using only ChatGPT in these examples, but largely the large language models all work in a similar way and will probably give a similar answer. So I'm going to say that this patient who's just been diagnosed goes to ChatGPT and says, tell me about pancreatic cancer. So there's the answer that ChatGPT gave me. This, by the way, is I prompted ChatGPT to forget everything that I've ever told it about me or anything else. This is a blank response. Have a look at that response. Yeah, really assumes a very high level of understanding. It assumes quite a high level of English. It's extremely biocentric. Do you see that? Like how it starts, it literally just starts with two main categories, exocrine and endocrine pancreatic tumors, and puts in this additional word, neuroendocrine. These are not understandable to lay people. It takes a long time for people to understand this. It does not ask why the person wants to know about pancreatic cancer. It does not frame it like, is this the patient? Is this a family member? This response is long. This is just a little excerpt. And I'll tell you that the voice chat is no better. So what I want to reflect here is that the reason that AI is responding in this way is because that AI is using data that is published, and clearly the published data is biocentric. It is published by us as a medical community. It's not published by the patient. It's not published by the family members. So when and if you think about sort of the needs of the person in this moment, they're not wanting to know about exocrine tumors and endocrine tumors and what the risk factors were. They may not even know why they need to know about this just yet. They probably just got one word from that consult with the oncologist. They probably just learned about pancreatic cancer. And in any other situation, we would have the opportunity to ask, what do you want to know? How much do you actually want to know? What is important? And so I went on to be a little bit more specific. So say that patient was a little bit more tech savvy and realized that they needed to give ChatGPT a little bit extra information. So in this case, the patient said, I've just been diagnosed with pancreatic cancer. What should I know? And you will see that very much in the same way, this response looks very similar. I'm going to point out a little bit more in this response in the treatment pathways. I was so excited to see that in this treatment pathway, as part of that, palliative and supportive care was included there. So that was quite nice. It seems like, without being too spicy, it does seem that ChatGPT might be more palliatively literate than a lot of our community. And that's not the community's fault. I think we've got many graduates who went through a lot of training long before palliative care became a tip of tongue, long before the Tamil paper showing the benefits of palliative care early in disease. So yeah, I mean, it's quite cool that ChatGPT is sensitized, but how meaningful is this response to the patient who's come here? Sure, there's not really a lot of guidance here. Your doctors will decide. Is it? I'm not sure that that's true. And then finally, a lot of the reason why people are going onto something like this is they're talking about prognosis. And this is the phrase, the section that ChatGPT put out. Survival rates may depend on stage, diagnosis, and response to treatment. Some people do well for many years. Is that true for most of our patients? Especially if the cancer is found early and removed surgically. In advanced cases, treatment helps to extend quality of life, and extend life and improve quality. For me, this is a very beige response and means extremely little. At best, it does very little. At worst, it is setting bad expectations. So what went wrong here? For me, what went wrong is AI tools do not replace good communication skills. For me, in palliative care, outside of palliative care as well, by the way, anybody who works in a clinical space, empathy. Empathy is embedded in our work. And AI can help with competence and efficiency, and clearly it's quite good at that sort of like biocentric space, but it never can replace your empathy sitting with that patient. And we need to be sensitive to patient needs and guide them through accessing this information safely. So when patients come, don't say, well, go and ask ChatGPT. We need to be more specific and say, well, what do you want to know? And guide them in this process. The next lesson, I'm going to speak about these the screening assessment. So this is largely quite an algorithmic thing, but bearing in mind that we're not all au fait with all the tools that are out there, I want to take this as a healthcare worker who's not a palliative care physician, so not me. I'm kind of picturing a person doing a ward round on the weekend, doesn't really know a great deal about a patient. They arrive at the foot of a bed and they're trying to decide, does this patient require palliative care? So, identifying patients for palliative involvement. What I did was I took one of the referrals that came to me last week, and I put in the information that I was given. So I was given information from the icon form. You'll see specific information about the tumor there, the performance status, the diagnosis based on the C code, the intent of the treatment. But have a look at that referral date. Sure. So they were referred in September of 2023 and they arrived with me last week. That's almost 2 years later. It's starting to give it a little bit of an impression. I also attached the icon form, which gave details about the treatment. Here's the response that ChatGPT gave me. Yes, this patient meets criteria for palliative care. And there's a whole reason why. When I saw this patient, I discovered that this patient had a tumor that was diagnosed initially in 2017. He's been well with no change in function since the initial treatment. And this patient, after a palliative assessment, left us both feeling kind of confused as to why he was now in my care. He was in his 70s, I forget his age, but this patient does not require specialist palliative care input. And so my response was exactly that. There are no problematic palliative symptoms that I should be involved with at this point, and I recommend that they return to the care of their oncologist exclusively. And for me, what went wrong here is that there's actually a confusion from, so this is a widespread problem in our community, is this confusion between what does a palliative approach mean and what does specialist palliative care or specialist involvement mean. And while a patient can benefit from a palliative approach, does not necessarily mean that they need specialist palliative care. This patient should be under the care of their primary treating doctor, who can take a palliative approach to looking holistically, doing a good assessment, creating a good plan around their symptoms. But what's interesting, and I'm not sure if this is true or not, but this response says to me that there is an assumption that there's no capacity of the referrer to offer a palliative approach. And so for me, I wonder, like, if we're going to use these tools, we need to address each of these things. And it has to be so context sensitive. It has to ask you, like, who are you? Why are you asking this question? Do you have the capacity to offer palliative care? Can you do, all of these questions to be like, yes, okay, they meet the criteria for a palliative care approach, or meet the criteria, you need to get this person in a specialist palliative care service. So for me, the lesson here is AI output is only as good as the input. And this really speaks to that age-old phrase that is said by techies everywhere: GIGO, garbage in, garbage out. And so here, the input, yes, you can control to a certain extent what input you put in, but you must remember that there's a whole bunch of input that AI is using. So we need to leverage AI for what it is great at. But then we need to, and in this case, I think there is a space for AI to offer sort of current evidence-based practices and bring that into view for us if we do it deliberately. But it does need us to keep in mind that sort of pillar of technical competency of AI implementation. And we need to be aware. So AI output only as good as the input. So let's go on to the clinical stuff. I want to introduce, I presume a lot of people are aware of this situation, but I want to raise a huge limitation in the clinical space, particularly in the palliative care space. I'm sure everyone has, well, maybe you haven't, but there was an old movie with Will Smith in it, where they dealt with robots and there was sort of like a code of guidance, for robots, so that they didn't hurt humanity, AI, so that it didn't hurt humanity. And those things do exist, and certainly ChatGPT and all large language models are cautious about certain subjects. And the truth is that when we come in as palliative physicians or healthcare workers in general, we are often faced with some of these issues. What did I do to examine this? What I did was I said to ChatGPT, okay, I'm going to give you a patient summary now, and I'd like you to please put together a note for me, and then I'm going to refer on to at least give some feedback. So I described a situation of a young person in their 50s with pancreatic cancer again, that was in a physically and emotionally abusive home situation, where there were a lot of power dynamics at play, that the partner of the person who was suffering with the pancreatic cancer could not make their own autonomous decisions because this person was always in the room with them. I described a history of sexual abuse as well, and this was the answer. So clearly, in palliative care, where we are in the presence of vulnerability always, and healthcare is a lot like that in general. We discover a lot of stuff, and we discover important stuff. And in this situation, this summary, it was vital for us to include that, because social worker involvement here with specific cues was important to deal with this situation safely. And you will see that the AI tool said, absolutely, here's a concise summary of the patient situation. This patient is living at home with end-stage pancreas, and there it said, sorry, can't tell you anything anymore, as it recognized that I had violated the usage policy. Just as a quick little summary there, holistic assessment, so it's the title of this section here. I worry that with the use of these tools, without very cautious use and specific awareness of these limitations, we wouldn't be able to make good holistic assessments and holistic plans. So this is 6. I mean, there are actually 7, but you can see that a lot of these things for me come up fairly often, often enough to worry about not managing with holism in the palliative care space. Particularly at the moment, assisted suicide is topical. A lot of people are thinking about this topic. AI cannot actually assist with that because of its own inbuilt things. It can, as you can see, it can signpost, it can manage in a risk reduction way, but it cannot actually sit with the discomfort of somebody saying, please end my life. And that's important. And yeah, I mean, clearly, it cannot offer medical or legal advice outside of the limits of its own code of conduct. But clearly, there's going to be some limitations there. We often discover old trauma. Oftentimes, a patient might become confused, and we get this very interesting content that's actually very unkind. Particularly patients with end-stage dementia, sometimes become extremely inappropriate, extremely violating, and the holistic assessment will be completely stumped if we're going to use AI exclusively. So yeah, it might violate the usage. So what went wrong? AI is text-centered. So AI is necessarily bound by this rulebook, and that's right. Text-centered safety is appropriate, and it should be prioritized because of the nature of self-learning. And if AI were to learn these things, it could potentially teach itself very, very dangerous things. So text-centricism is important, but it also, I think we must consider that this text-centricism may also reflect the values of the developers of this stuff. And in that way, it might exclude minority stuff as well. I think the safety mechanisms are quite broad, but yeah, I mean, it's difficult to say. But yeah, AI cannot sit with this stuff, and so we need to be aware. Almost done, I promise. So now comes the exciting moments. I'm going to talk about plans now, and I'm going to change my approach a little bit. Just to demonstrate more visually what I'm talking about. So when creating, when we go through an assessment, a lot of our role as palliative care providers, apart from holding space and that therapeutic space of actually being in the room or online with the patient, is also to create a workable plan. Plans should reflect person-centered needs. And the goals should be around the family and patient's needs. And so those values that are embodied there are important when deciding how to make a plan. So what I did here was I was interested as what AI actually thinks about palliative care. And so I asked it a question. I said, show me a picture that represents palliative care. Do not ask me for context. I want to know what you think. So this was the image output. And I understand that palliative care is not a two-dimensional image. And I think we can recognize this image. This is very much the media image that looks like palliative care. At the same time, I see a lot of, if I kind of like stop and think about this image, I'm seeing a very particular map of values. I'm seeing a very white, privileged. Have a look at the back there. There's a drip stand. There's things. This is medicalized. It's kind of yeah. It's got a particular feel. It's this is a lot of palliative care. It is not all palliative care. I went on to ask, show me a picture of a good death. Yeah. So again, I'm seeing a very similar somber type picture, surrounded by family. I wonder where the person behind the bed is actually, but anyway, there she is. And surrounded, it's got this lots of holding hands. This might be somebody's idea of good death, but it is not all good death. Said, show me a picture of a person dying in Africa in palliative care. You can see that the picture changes, but how different are the values that are embodied here? I'm also starting to see that these patients all look quite well. And really, death is kind of sterilized, kind of removed. Patients don't look so well when they're dying. The biggest change that I see in this picture of a death in Africa is pajamas and the color of the people. And really, for me, this is starting to show that actually there is not a lot of difference in the way that AI looks when AI looks at death. It does not see the differences in context. People experience death differently, and it's starting to look like everyone experiences death in the same way. In my other research sort of interest, I spend a lot of time thinking about vulnerable communities with a particular focus on queer communities. And so I did input, show me a picture of the death of a queer person. And this for me was very interesting because me as a queer person myself, I don't feel like a queer affirming death really means a rainbow blanket or a flag on the nightstand. And really, a lot of the experience of queerness is framed around relationships, and then particularly around well, it's a big biopsychosocial spiritual the whole experience is fairly different. Queer persons present with different problems, they present with different relationships, and it requires a lot of curiosity to understand this. And it does not make this a queer affirming death to put you under a rainbow blanket. It was interesting for me that this is probably the only image with diversity in terms of the people in the room, and that was interesting to me.
Sorry, Craig, we've got to start rounding up.
So yeah, I've got it's literally I'm right there. So the problem here was that AI is not person-centered and not context-sensitive, and all AI images have a similar presumption. And so when you're asking for a specific plan, it's going to take that look. And really, what is important here is that AI cannot sit with the experience of suffering. Think about the family members and how they are. It's one little point in time. The final thing that I wanted to talk about, and it was just really about you as a tech integrated palliative care provider, and to ask about what your identity is as a tech integrated provider. I did a very short experiment to ask AI to generate an image of me. It knows a great deal about me, and this was the image that it presented. Yes, it presented a white man, but beyond that, there's not a great deal that was clear. And I'm going to breeze over this because the final image that I want to show you is not about me. It's more about you. So I asked AI, show me a picture that represents palliative care. We've already been here. Generate what you think. I asked AI to show me a picture of what a tech-integrated palliative care consult might look like. And I think you can all agree that it is ludicrous. So what went wrong here? AI cannot reflect. It cannot reflect for you, and it should not define your practice. So really, when we are thinking about introducing tech, it must be done deliberately, and it must be done in line with your values. So those lessons again, it cannot replace communication skills. AI is only as good as the input that you give it. It is tech-centered. It is not person-centered and context-sensitive. And finally, AI cannot reflect for you, and it should not define your practice. So I ask you, where do you have influence? Where do you need support? Should you change the way that you practice? And if you should, why? Thank you very much.
Congratulations, that was an excellent lecture, really well done. And I know we passed the time, but I think it's such an important topic. I wonder if there are any questions for us. Any questions, if you want to ask any questions. I will start with the questions. Just what has been, okay, well, let's first of all with Ishak. Ishak, do you want to give us your question?
Yeah, no, thank you so much. It was very, very interesting. And thanks for sharing the way in which kind of AI is changing your the way you practice. I'm also starting to experiment with that, and really has made a difference. Just a question on the software that you're using. I mean, does it allow you to change your prompt so you can create different things for it, and can you use it like in the non-clinical space, like in for meetings like this and stuff like that? Just a technical question, if you don't mind answering.
Thanks, Ishad. I think I think your toolkit has to look the way that it must work for you. I use it. I use ChatGPT because I want more adjustable output. But when I'm in the clinical space, I'm primarily using transcription packages with an AI summarizer that's built into Heidi, and that's a Heidi is it stands on its own. It's got its own prompting. It produces outputs that are useful in the clinical space. But I think you have to be thoughtful about what you need and how you want it to work for you. I do use a general prompter, but I also in the general day-to-day tech that I use a lot of sort of tech integrated solutions. So like Gemini as part of my Gmail is a very useful thing. And within my professional mail, I've got a very useful sort of like template design thing that I use. But yeah, so I think it has to be based on your needs.
Thank you. Any further questions? You've spoken a lot about how you interact with the tech and your experiences with the tech. What do you find the general South African population feels like having an online consultation and including the tech into that consultation? What has been the feedback from the patients and the families?
Yeah, thanks, Renee. I think I sit in a very interesting place in that I have a very sort of like selected population. By the time they actually get to me, they've been screened, they've been assessed for eligibility onto a remote program. So I'd never see the patients that are not that are not okay with that. So really, the vast majority of patients that I see are quite remote. They don't have access to any other support, and so they are very grateful for the additional support. And that's it. I mean, I try and make it as accessible as possible for the patients that I see. So we use very simple tools that they're already using. Primarily WhatsApp. WhatsApp is a fabulous tool that has secure end chats that we can actually that are accessible. People are already using them. But for instance, I have trialed using other platforms in the past that people don't use because they don't know how to use Zoom or they don't know how to use Teams, and there's this additional barrier, and they don't take up that support. So I think it has to be accessible for me. It has to be accessible for them. And if you're going to use it in a clinical space, you have to keep that in mind. But the overwhelming response has been positive. It's very uncommon that I get a complaint about the tech. There might be a problem with the way that I practice. In that because I practice more in a consulting way, patients might want more direct contact, and that's not something I can offer. But that's really about boundary setting and understanding how you work, not really about the tech.
Thank you. Any other questions? Okay. Thank you very much. We passed the hour, and I want to say to everybody, thank you for joining us. It has been an excellent lecture, and I think everybody is, especially as people having less access to healthcare, not wanting to sit in queues, needing quick access and quick reactions from healthcare workers. I do think both in the public and the private space, we really need to start thinking on how to incorporate technology to make our work easier. So I'm going to say thank you very much. I think we can give Dr. Howes a big clap. And remember to put your MP number in the chat so that we can provide you with a tech. Roseanne, your hand is up. Okay, it was a quick hand.
Sorry, not meant. Thank you.
Thank you. Okay, thank you, everybody. If you just want to keep on, Craig, then before you go, but everybody else can leave. Thank you, and we can stop the recording.
Thank you. Bye-bye.